So basically we see that it's a ma'am, it's like you have an AL1, right? AL1 is little bit traumatic to the right coronary artery because of the long tip. So this is a shorter tip. You call it as the short left amplats. You can call it as 0.75 amplats. The other one is AL1. This is 0.75. The advantage is it's less traumatic to the RC ostium, and it gives enough and more of support. Support. That's the greatest advantage of that. Orbital, yeah. Ah. With microcatheter, wiper wire. Yeah, the stent is actually in the proximal RCA. The rest of the things, it's all calcium. It's all calcium. Heavily calcified vessels. It's more than with the microcatheter. We'll go with the microcatheter. Almost 21 years ago that was done. അന്നത്തെ സ്റ്റെൻഡ് അത് നന്നായിരിക്കുന്നു. അമൃതയിലല്ലേ? അമൃത ഹരിദാസ. അത് കഴിഞ്ഞിട്ടാണ് ബ്ലോക്ക്. കഴിക്കുന്നതാണ്. എത്ര how much did we give? 1 milligram midazolam and 25. We give 0.5 midazolam and another 25 fentanyl. അത് വേദന കുറഞ്ഞോളും. Microcatheter might not cross the lesion. Microcatheter might not cross the lesion, so we'll push it into the lesion and then remove the wire and go with the wiper wire. Can you transfer the shoot? Can you transfer the image? Here it's a calcified right coronary artery and a proximal stent which looks good. So our plan would be to open up the distal lesion with orbital atherectomy and then do an imaging followed by a balloon-based strategy. Balloon-based strategy, probably an IVL or a non-compliant balloon. We'll keep a reasonably good guide extensional catheter also ready. Even though it takes some time to cross the lesion, you are always happy with the regular workhorse wire. You can always go in for with these sort of calcified lesions, you can always go in for a fielder FC wire, which probably would cross the lesion much easily. But then you're always comfortable with your workhorse. Even maybe it might take another couple of minutes extra to cross the lesion. Is this microcatheter a New York one or is? Keep monitoring the saturation, somebody. I didn't know that you all had come. Otherwise, we would have started at least 15 minutes earlier. I called up Krishna Priya. She told he's still waiting at the lobby. Just 2 minutes ago, I called. So another two persons are still waiting there, is it? I was. No, the microcatheter is not. I just. Even if it doesn't cross, it's not a major concern because we can get the wiper wire over the partially crossed microcatheter. Okay, now the wiper wire. Yeah, it's a fine cross catheter. Introducer. Introduce. We are given 1.5 milligrams of midazolam and 50 fentanyl, right? Yeah. Now get ready with the orbital device. No, OCT will not cross. OCT will not cross the distal lesion. So again, in these sort of heavily calcified lesions, many a times, even after rota, previously we had been using mostly, you're doing rota for most of these patients. Now only we have switched over to orbital. So even after rota with 1.75 or 2 bar, most of the times you find it extremely difficult for the OCT catheter to cross the lesion. We'll slowly take it up. We'll take this out, microcatheter. We commonly use 7 French, usually 6 French for most of the interventions. These sort of bifurcations and all, if we are planning for bifurcations and calcified lesions, mostly it's 7 French catheters. Most of the males will be able to accommodate 7 French guide in the radial artery. You have seen that he had some pain, you just have to sedate him. But females, it might be difficult at times, but yesterday's afternoon case we have done with the 7 French multi-purpose catheter. The RCA was done with the 7 French multi-purpose. We always give little bit of sedation. Sheath is the slender sheath. Slender sheath. That's a Termo one. It accommodates a 7 French catheter, but then the outer diameter is as similar to a 6 French sheath. It's a very flimsy sheath, and that it's very thin. Second time you use it, it's always difficult. Okay. Aditya, Sri Lakshmi, be ready with two things, Sri Lakshmi. A 6 French compatible guide extension catheter and a 7 French compatible guide extension, both. Be ready with both. Shahidi, can you hold it straight? Straight. It's not going through it. It's not going. It's all New York things. It's not going. No, that's not an issue. Lock. Okay, lock is also. Okay, now it's good. It's come out, right? Okay. Okay. So. No, this is the first time it's getting stuck somewhere here. With rota, it always, many times when you use a reuse rota advancer, you get stuck over here, no? Something similar to that, but when we held it straight, it just went through. Okay, so now we'll check the parameters. We'll keep it in lock position. This is again in lock position. The flow is good. There is no air inside that. Fill the chamber once again. Fill the chamber a little bit. Little more. Okay, that's fine. We'll switch it on. That's 80,000 RPM. The saline is also flowing well. Okay, now probably. Yesterday we tried attempting the glide assist mode, but today we might need the glide assist mode to reach the lesion as such because of the proximal stent and things like that. We might need it might be difficult for us to go in through the proximal segment just like that. Yeah, we might need the glide assist mode. വേണ്ട. Okay, we'll go to glide assist mode and then push it through. Ah. Yeah. No, it's okay. Now this blinking light is glide assist mode. Yeah, now it no glide assist would work without the brake locked. Okay, now we have locked it. Glide assist, you just have to give a slender push. It just went in. It's 5,000 RPM. 5,000 RPM. It went in without difficulty. Yeah. Anyway, that area there is certainly there is lesion there. No Brady till now. Keep the fluid is on flow. Keep ready with the noradrenaline also. And if at all needed, we'll go start tirofiban also if we develop slow flow. Pardon? Almost. We'll be ready with a New York OCT catheter. Once, because it didn't cross, orbital didn't cross. Probably if we have time, we'll discuss those cases also today. Then we'll settle this with 80,000 and 120,000 RPM and then go to the distal segment. Now we have gone, yeah, now we have switched over to 120,000. Now we have bradycardia. Keep atropine ready. Yeah, yeah. 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 Sinus. Joby, we'll do one more burring at 120,000 in the proximal segment. Once more. Then we'll go to this. We'll wait for a while till the rhythm settles. So at 80,000 RPM, we did not see any AV block or slow flow. But now at 120,000, we saw AV block, bradycardia. There should be some slow flow also. The disadvantage here would be why we decided this way is, see, now you need to park the burr, you need to park the crown closer to the second lesion, right? So if you have prepared, the proximal lesion flow will be happening by the side. So otherwise, with a lesion like this, you're getting the crown over there closer to the distal lesion. The perfusion may not be good. So now we have settled with the proximal lesion. Now we go do the burring of the polishing or sanding of the distal lesion. No. We don't have to do it this fast. Probably the movement of the crown should not be seen on the monitor. Slow, so slow should the movement be like. Temporary has come out. It's all right. No, not an issue. We'll come back, come back, come back, come back, come back and stop. Come back and stop. Come back and stop. Okay. And in between it missed pacing. Show the next run. Show the next run. Oh, there is a television. Many times with rotablation, when you do the rotablation of the distal lesion, the flow becomes better and the AV blocks tends to disappear. But this might be slow flow related to the lesion as such. Okay, be ready with Nicoran. We'll start tirofiban now. Be ready with Nicoran and SNP also. Okay. Yeah, we'll go this. It's almost near the lesion, so we'll go at 120,000 RPM itself, because otherwise it might not cross the lesion at. Now it has crossed. Now we are coming retrograde. Now we'll go. Both antigrade and retrograde sanding is possible. Yeah. It's happening in between. It missed pacing, but now it's pacing well. Yeah, it's paced. Now it's sinus. Yeah. Did we have to give atropine, Pradeep? Atropine kodukkendiya. And that's why the BP has gone up. Pradeep, why today? Why today? We didn't want you to come.
Not like that.
You're welcome always. We'll go up once again and stop. 120 at 120 and stop. Because BP is holding on, there is definite ST elevation. Be ready with Nicoran. We'll give Nicoran SNP once we are out with this. One more sanding we'll do and then stop. Always, as you keep doing more and more times, the number of it's actually the luminal gain is proportional to the number of passes. That's what we discussed yesterday, no? With at 120,000 RPM, 10 times will fetch you almost 2 millimeter luminal area. 5 times will fetch you 1.6 or so. They have done with the chalk model studies and all. We'll go once again. Yeah, we'll go. They've actually given some. 120. OCT New York. Okay, 25 seconds. We'll stop. Now we'll go to glide assist mode and then release the lock and then we'll take it out. जो भी wire feed ചെയ്താൽ മതി. Okay. It will come out by itself. You always, it's always good to do that. You can do it the other way around also. Sometimes. Yes. Little more. Yeah, ma'am. Pressures are okay. Now we'll take this out. We'll do a cine and then give some Nicoran SNP. Usually acute MIL കൊടുക്കാറുണ്ട്. SNP is also. We'll see the image and then decide on that. Yeah, we'll give. Okay, flow is good in fact. Fully open. So we'll give some Nicoran. Run through and OCT catheter. Yeah, we can do that, but it's cumbersome. No, it's 300 centimeter long to feed it. Otherwise, it can be done. Even we have done stenting over the wiper wire. Yeah. SNP. We are doing we are doing imaging. That looks reasonable. Okay, now we'll go for run through wire. Okay. Run through OCT catheter. 4 mm NC balloon. $412. Safe, is it not safer to go with the microcatheter and exchange it? That's the question, like, right? Yes, certainly it can be done, but angiographically we felt that the lumen looks okay. We'll be able to, when it's a difficult lesion, certainly we'll go with a microcatheter and exchange for a workhorse wire. Talk. Even rota, even rota also that's how we do routinely, and that's PDA. But there is some lesion in PDA, so it's safer we go to PLV. Shall we take out the wiper wire? Okay. Now the OCT catheter. Somebody, can you hold the wiper wire? Okay, this is a New York OCT catheter, right? Surprisingly, the T wave that had inverted, it's still upright. Despite having a reasonable flow. but the flow is in fact not bad. We've seen the lumen, right? Did we do the auto calibration? We'll do it inside the coronary. Okay. They say that for this particular catheter, you really don't have to do auto calibration. Okay, now get me an guide extension catheter. No. Uh, 6 would be enough. 6 would be enough. We'll take this out. OCT catheter, we'll take it out. Guide extension catheter. We have started tirofiban also, right? Okay, okay. Guide extension. Okay, now we'll take the Endo Anthony. എന്തുവാ എന്തുവാ കയ്യിൽ വേദനയുണ്ടോ? OCTക്ക് എത്തിയിട്ട് we'll go through the guide extension catheter so that we'll get a better pushability to cross the lesion. Okay, now give us 4 balloon. If this doesn't go through, we'll go with a 4 balloon and dilate it and then do OCT imaging. Yeah, it's crossed. Still it hasn't crossed the calcified lesion. That nodule it hasn't crossed. We'll go. No, it wouldn't go. Yeah. Okay, so we'll do the imaging. Jojo, you ready? No, it didn't cross the distillation. It's just at the distillation. Okay, we'll do the imaging. That's good. Side port is good. Don't do anything. Okay, so we are ready. It's almost crossed the lesion. Okay, ready? Yes. Yes. I'll say activate. Activate. Okay. Okay, the image looks okay. I'll take this out. Now give the balloon. Four balloon. Yes. 4 balloon. Jojo, show the images. We will take out the aspiration catheter also because 4 balloon won't come out mostly through the after dilatation. It may not come out through this, so we'll take it out. But we are taking in New York, it should go through. Okay, we'll dilate with that. We'll see the OCT. Vessel size is anyway 4, right? 4. This is actually, we are on the nodule. That's the nodule. So it has been shaved off. It has been at 2 o'clock, 3 o'clock position. We are seeing that nodule. There is a hole in the top of the nodule has been shaved off. So we have just crossed that nodular area. Now we need to further dilate it either with IVL or, so these are the areas again. Some amount of sanding has been done. Now coming to the proximal lesion. Here again there is so much of calcium, and these areas, no, we are seeing eruptive nodules wherein there has been some sanding with. We usually do not see any fractures after orbital, but here there appears to be some, but no. Okay, that's it. We have done enough with the. We try with NC balloon 4. If it opens up, we can keep the IVL for. Pratibha, even yesterday's patient, he kept his eyes open and slept. Ketamine. Even as the first time I was noticing that renal failure patient, the one with renal failure, he was sleeping but his eyes were open. Now see. Okay, balloon. New York balloon. Awake anesthesia. Be ready with the stents also in case we are able to open it up. Be ready with the IVL also, for IVL. It's almost 4 mm. We go with a 4 mm balloon. It appears to be much bigger than 4 mm. So at least 4 should be needed for this. Oh, Vishnu, size, distal vessel size, it's crossed. Yeah, it's a New York balloon. No, we expected that it would go, because the problem with a 4 mm balloon is after dilatation, the profile will be bad. So taking it out through the guide extension will be difficult. So you'll have to take out both guide extension and the balloon together. Together we'll have to take it out. But we felt that so much of burring has been done, it should cross. Huh? It's open. Show the cine, previous cine. Okay, we'll come back little bit. Okay, again we'll go up at 14, 16. 14, 16. Okay. Yeah, it opened up very well. Okay, 14. Negative. Vishnu, is the vessel size 4 at least? 4 at least. Huh? Okay, 14, 16. 438 stent. Huh? 3.5 and post dilatation. Okay, 3.5 and post dilatation. Yeah, anything is okay. 14, 16. We'll get the guide extension also. We need anyway 2 stents, right? We might need 238 stents. Okay, negative. We'll pull it back couple of 1 millimeter and 2 millimeters and once again go up. Okay, 14, 16, 18. Before we take out the balloon, we'll take a gentle puff. Make sure that there is no perforations. Okay, that looks perfect. A cine also then. Should we do an OCT run? We'll do an OCT run before stenting. because anyway he's stable. Pratibha, before stenting, we'll take another 2 minutes extra. OCT catheter. Despite opening up this much with a balloon, at times the OCT catheter may not go through. Still may not go through. Perfect, perfect. Just 2 more millimeters. Okay. Yeah, it's open. Okay, so imaging. ഞാൻ ഇഞ്ചെക്ട് ചെയ്യട്ടെ ജുബി. Okay, we are in. Shall we do visit? Yes. Enable pullback. Activate. Now give us the stent. Did we open 3.5 or we didn't open 3.5? If we haven't opened 3.5, we'll go with a 438. Do we have a second 438 also? Anyway, 438. Vishnu, regarding the lesion modification, it's open up. The lumen is quite good, around 6, 7. 438. Give 438. Might go in. Vishnu, mostly it's all eruptive nodules. It is not nodular protrusion. It's all eruptive nodules. It has been opened up really well. Usually with an eruptive nodule, what we see following a balloon dilatation is it gets deformed. The top of the eruptive nodule, it gets deformed. We do not usually see any fractures with a balloon dilatation. But then when you use an IVL, two things happens. It gets deformed, and it also you can see some fractures with IVL, with even over the nodules. That's fracture. Anyway, proximally we would see over the nodule, we might not see much of fractures, but proximally all those areas we've dilated with 4 millimeter balloon. So obviously we should be seeing fractures there. We are seeing multiple fractures over there. Come more proximally, Vishnu. More proximally. Again dissections, fractures, because it's a diffusely calcified vessel. All, yeah. Again the lumen is quite good. Fractures and dissections on Vishnu, these are dissections, those are dissections, these are dissections. Vishnu shows the fractures also. That calcified areas you can see other fractures. Again, korchuda clearer images. We'll go for Guide Plus. Those are fractures here. Over here, this calcium. Uh, this fracture, this is calcium, in between. Yes. Like again, doesn't make much of difference. Whatever said and done, it's opened up. So then we'll get a proper stent expansion. Vishnu, even can we see the vessel size is almost 5 millimeter? Looking at the EL to L. Here. EL to EL, it's almost is from there. Further we need to go. Almost 5 millimeter. It's further distally. Almost 5. At least we'll go with a 4 post dilatation. Yes. During every conference, we hear that guide plus should not be taken like this. It should be always taken over a balloon. But then the advantage of guide plus is the stent didn't go, the guide plus has crossed the lesion. It's so trackable device. This is. The 3 anyway, we've taken it. We'll go deploy it. Then give the next one, we'll take 3.5. Show the shoulder of the guide extension. Don't push, we'll spoil it. Okay, I think we'll take it out. It's we won't take it out, we'll keep it outside. We'll keep it here. We'll feed it into the guide plus. And then we can go. It's deformed, little small but we'll manage. Otherwise, we'll have to throw it away. No, we just try to feed it into that, and now we'll go to we just hold on to the wire. With both together. Yes. Yes. Anyway, we'll push the stent. Now again, we'll push the other thing also together, because the stent, otherwise it might not cross the lesion because it's partly deformed. So now it should go through. Yes. Now we'll take this out. Yeah, taken it back into the guide catheter. Joby's threshold of throwing away stents is very low. My threshold is. Shall we deploy? Should we come back? We'll come back a millimeter.
Sir, can we have a live screen?
Okay. Okay, I think we'll go up there. Okay, 10, 12. 10, 12. Negative. 438. We'll check the length. Okay, this much. This would be another 38. Yeah, that's enough. Another 38. If you have 3.5, we'll go with 3.5 and post dilate with a 4. We'll take this out. 38. We need 38. Adellam sada stent in the cost. It's. Do you have 1 second? Do you have 4 of here at least? 4 CRR 38. We need 38 at least. Then give 3.5. We'll anyway post dilate it. Yeah, certainly. Even a 2.5 can go up to 6. We have tried it. Yeah, I show you that videos. Anyway, it's a proximal lesion. It should go through. The stent should go through because again it will get stuck on this. Okay, BP is good. Give the next stent and then a 4 NC balloon for post dilatation. And that's the second stent, another 38. So this time we've taken out the guide extension because initially it had actually, the stent had hit on the guide extension and it got deformed. This time it should go through. Yeah. You have the shoulder of the guide extension, no? It is getting stuck there. When we try to push it across, it gets degloved. 1 millimeter back. Yeah. We'll go up there. 1 millimeter. We are touching the stent. We are not significantly overlapping. 14, 16, 18. And 4 mm balloon. Negative. For post dilatation, and then we'll do OCT. We've given 7,500, and after 1 year usually we give another 2,500, and if it's a very complex case, then we check the ACT. This is 4 into 12, right? Yeah, he should be around 75. 12 and negative. But we've been using Beparin for quite a long time, isn't it, Joby? Guide extension, the 4, you'll find it difficult to get it through a guide extension catheter. The profile is gone, so we'll have to push it through. Yes. Yeah, we'll go up to 14 or 16. Negative. Again 14, 16. Negative. Fourteen, 16. Negative. 14, 16. Yes, certainly. Because it's an unpredictable RCA. Today everything went on well without any difficulty, but things can go wrong. So always an IABP, in the best center probably an impella. 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 Out. Not for everyone. Yes. We are done. തീർന്നു കഴിഞ്ഞു. Almost case done. Negative. 16 and 18. And we'll stop. 18. We've gone up to 18. Yes, certainly. Certainly. Once again, we'll just go up to 4 atmospheres. Just small pressures, 4 atmospheres. There is a small plaque. We wouldn't do anything for that. There is a calcified ISR in that particular area. While doing OCT, we should probably concentrate more on that particular area, the initial stent. We'll do a survey mode pullback, not the regular pullback. OCT catheter. If it doesn't cross, survey mode is 75 millimeters, and the other one is 54, yeah. 54 and 75. Joby, the other one also will go with a 7 French guide catheter, alle? Yes. Radial, if it accommodates 7, probably will go. Okay. We'll have to take 2 runs to see the entire RCA. I tried to manipulate the guide and the OCT catheter came back. Okay. We'll try to push. No, the guide should be properly in. No? And now it's good. Now it's good. Okay. We are ready? Yes. Yes. Activate. Vishnu, we'll take one more shoot and then evaluate this, the proximal RC. Get ready with the next shoot also. Okay, one more shoot. Ready? New recording. Okay, ready? Auto calibrate. Enable pullback. Activate. Okay. Nitro. Show us the last run. Nitro, we'll evaluate the second image first. Second image first. Joby nitro in kodukam. Second image first so that we can see the proximal portion of the old stent. Can you enlarge the OCT image on the monitor? Okay. Now here we have the new stent stopping shot, and that's the area based on. Okay, now more proximally, we are now this is the new old stent. We have significant calcium inside the stented area. So that's the calcium inside the stented area, neoatherogenesis, but then the lumen is okay. It's 5 millimeter square, 4.8 millimeter square. We need to make sure that there is no significant dissections produced because of the stents and the guide extension going through that particular area. This is just an intimal disruption. It is not actually moving into the media. And you can also see some calcium over there. The lumen area is quite good. It's almost 6 millimeter square. Then again, this is calcium inside the stented segment at 2 o'clock, 3 o'clock position, suggesting that it's a neoatherogenesis 20 years. Probably it was a bare metal stent in 2003. So this is what we see in most of the bare metal stents. So significant calcification over there. And again, the lumen is good. So I think we wouldn't touch that particular area. Now we have reached the guide catheter. So as we go into the vessel, the old stent looks okay. The luminal area is reasonable, 5 millimeter at least. Yeah, everything is more than 4.5, and there is no significant dissections except some small intimal tears and some white thrombi red thrombi over here. And then as we go into the distal stent, the new stent, the second stent that is deployed, it looks, we'll remove the rendered stent. Now as we go into the stent, it looks reasonably opposed. The luminal areas are quite good for 9 millimeter, 10 millimeters and all. Here we have an eccentric expansion, but still the luminal area is almost 9. So that's acceptable. It's well opposed. That is some plaque prolapse. That's plaque prolapse at 6 o'clock, 12 o'clock position. Again, plaque prolapse, it needs to be given importance only if it occupies more than 20% of the luminal area. Here there is some malposition. But here, if you look at the longitudinal image, you can see that there is some ectasia like over here at that particular nodular area. No, this is the area. That's the area. So as we go further distally, it looks reasonable. Good lumens. We'll see the initial image also post PCI. We are beyond the stented segment. Beyond the stented segment, the luminal area is 8.2. As we come into the stent, we look for dissection. Okay, there is no significant dissection beyond the stented area. Now we'll remove the rendered stent and then slowly pull it back and see in the cross-sectional image, the stent appears to be well opposed, good lumen, 9-10 millimeters. No, we can see these struts very clearly once. So that's the only area wherein we see that it is not well opposed. Here I think it's a small branch or so. So I think we don't have to further post. Joby, we'll have a nitroglycerin injection and stop. Oh, here there is a, yeah. We'll once again co-register and see this particular area. One spot, I think mostly we didn't be doing anything over there. We'll once again, once you co-register, you'll get an idea regarding that in a better way. Illa Joby, this area alone, 1 second, this area alone, it's not very well opposed. That's actually the more proximal area of the stent. It's over here. I think the co-registration was not proper. No, yeah, the co-registration was not proper, I think. Jojo, can you you can't co-register once again? No? You can't co-register once again because this run is actually the distal run. This is actually the distal run, not the proximal run. Isn't it, Vishnu? This second last run. Second last run. So it should be somewhere this small thing. I think we wouldn't further 4.5 not needed. We'll settle down with 4. A small area wherein this is the small area wherein we haven't opposed it very well. That's not an issue, I think. 400 microns. This is definitely more than 400. This area is definitely more than 400. This would be around 200 microns or so. These areas, it should be 200, but this should be some 500, 600. But it's only very small areas and 700 microns. I think last shoot and we'll stop. Good, better than what was expected, what was anticipated. Epicranial. The T wave has started getting inverted. So we'll remove the temporary and then do the final shoot. We'll remove the temporary. So then image will be better. Echo machine RL on Geo. Can you switch on the echo machine? Show the distal vessel. Okay. I think we'll stop.